Good morning, everyone. I'm Dima El-Sharkawi. I'm a haematology consultant and I work at the Royal Marsden Hospital. It's an absolute privilege to be here with all of you today. So I am going to take you through some of the basics now of WM. So revision for those of you who've already lived with it for a long time, but useful always to revise these things, and obviously good for the newbies here as well. So, diagnosis and potential symptoms. So this is the tree of life for haematologists. This is what we live, this is what we breathe. So you produce all your blood cells in the middle of your big bones, in your bone marrow. And you've got something called stem cells, and they can eventually become any one of your blood cells. And they can essentially either go down what we call the myeloid route or the lymphoid route. The myeloid route eventually becomes either your red blood cells, your platelets, which are the little fragments of cells that help your blood clot, or your white blood cells that help form part of your immune system. Down the lymphoid route, you either get essentially B lymphocytes or T lymphocytes, and these are part of your immune cells as well that help fight infection. And some of your B lymphocytes can become plasma cells. So you will all be aware that there are lots and lots of different blood cancers, but essentially we classify them based on this tree, and any one of these cells can become cancerous. And so WM is basically a cancer of the B lymphocytes that are kind of becoming maturing to plasma cells. So with WM, you've got the lymphoma aspect of it. So your B lymphocytes have become abnormal, that they're continuing to divide and that they've escaped the normal control that we all have of our blood cells. But not only that, your B lymphocytes, when they become plasma cells, they produce something called antibodies that help them in their function to fight infection. And so as you produce more of these abnormal B lymphocytes or B cells, you produce more of the antibodies as well. So WM is quite unique in our lymphomas that we treat, because not only have we got the lymphoma aspect of it, so the abnormal cells, but we've also got the abnormal antibody that's being produced. So you might sometimes see either on your notes or in your reading that, and probably what we all do as healthcare professionals, is we use various different acronyms or names synonymously. So you might hear a term called lymphoplasmacytic lymphoma, and that's referring to the abnormal cells that you've got. So by definition, anyone with WM technically has lymphoplasmacytic lymphoma, but WM is the combination of the lymphoma, the abnormal cells, plus the abnormal antibody called the IgM paraprotein. So the two of them together is what we label as WM. And so the paraprotein is detected by, as sometimes I should say, it's called an M protein or spike protein. It's detected by the blood test that we do. And so sometimes the blood test, you'll see it referred to as a protein electrophoresis. So some of you, the way that your disease may have been diagnosed was because people had picked up in a blood test that you'd got this abnormal paraprotein. So that may have raised the suspicion of lymphoma or WM, but it's not diagnostic itself, because obviously we need to prove that there's the abnormal cells as well. But once you've had a biopsy, it confirms the two. So let's talk about the symptoms that you might get with WM. And again, if you kind of think about the logic of where it's produced, it starts to make sense as to some of the symptoms you might see or experience with WM. So first of all, you can get the symptoms related to the lymphoma side of things. So as I already told you, the lymphoma cells or your blood cells originate from your bone marrow. And if you're producing too many of the abnormal cells, so the lymphoma cells, then it'll stop your bone marrow from producing your normal cells. So if you get a reduction in your red blood cells, that's when we say someone's anemic. So when we're doing your full blood count, when we're checking your bloods in clinic, we'll be looking at your hemoglobin level. And if that's low, then the symptoms you get with anemia can be shortness of breath, particularly on exertion. People generally notice it first when they're going up hills that they really realise it, or you get fatigue as well related to that, because your red blood cells carry oxygen around the body. If you've got low platelets, and I told you they're the little fragments of cells that help your blood clot, you might notice that you get bleeding or bruising related to low platelets. And if you've got low neutrophils, so these are your white blood cells that help fight infection, then you'll be at increased risk of infection. So these are all symptoms you might get from the lymphoma affecting the bone marrow. But the lymphoma cells can also affect the lymph nodes. Now, this often isn't such a big feature in WM, so often patients with WM don't have enlarged lymph nodes, but there will be a proportion of you that potentially do, and that your disease presents perhaps, or also includes swollen lymph nodes or a swollen spleen that can either be detected by you noticing a lump or a clinician noticing a lump, or perhaps from a scan where it's picked up that you've got an enlarged spleen or an enlarged lymph node. And as the general burden of the disease increases in the lymph nodes, people might get what we call generalized symptoms as well as localized symptoms from the lymph node. They may get fatigue, loss of weight, or night sweats as well. So that's from the lymphoma aspect of it. But as I mentioned to you, the WM cells produce this abnormal antibody, the paraprotein, and the paraprotein goes round in groups of 5. So in my very basic diagram here, you can see that they're quite big molecules, and so they can make, when they're very high, your blood essentially thick, and that's what's sometimes referred to as hyperviscosity. So these big molecules, if you're producing a lot of them, because of their size, can cause breakages of the small blood vessels. So you may notice that you get nosebleeds, changes in eyesight, or perhaps headaches as well, related to an increase in these antibodies. But not only that, a proportion of people, their paraproteins, their abnormal antibodies may develop complications that not everyone with WM will get. And these may be things that are more common, like neuropathy, so it affects the little nerves in your fingers or toes if the antibody deposits there, or the way that they fold can be different, and you can get potentially rare complications related to the paraprotein. So I think that, there's a whole host of symptoms people can get, but understanding the basics leads us to kind of understand why people may get the different symptoms. So I've told you about all the symptoms, but we need to first of all make the diagnosis. And like any cancer, the only way we can make a proper diagnosis is by biopsy, so seeing the abnormal cells. You can be suspicious of it from the abnormal blood test, but without a biopsy, we can't prove someone's definitely got it. So the picture on the left is a picture of cells that are in the bone marrow, so Waldenstrom cells, and so we look down the microscope at the bone marrow and we can look to pick up the abnormal lymphocytes, the abnormal plasma cells, and see that they're increased. But as well as seeing the cells, we've got more sophisticated ways, if you like, of detecting whether it's, first of all, a lymphoma, and if it's a lymphoma, that it's Waldenstrom. So we can do various stains to look at the surface of the lymphoma cells to see what proteins they express, and there'll be a certain characteristic pattern of proteins that are expressed on the cells that we can stain for that can help us diagnose it. But we can also now look inside the cell, and this is being done more routinely in the NHS and worldwide, and so we can look at the genes that's in the DNA within the cells, and you'll see that I've got a list here of some of the genes that can sometimes have mutations, so if you like, mistakes in the coding of these genes, and some of these are very frequent in WM. So, for example, most patients with WM, if we look at these abnormal cells, so it's not in all your cells, but in the abnormal WM cells, the majority of you will have a mutation in a gene called MYD88. So that can help us from a diagnosis perspective, but also by better understanding the disease and what goes wrong, it'll help us hopefully develop better, more targeted treatments going forwards. So once we've got the diagnosis, we stage the disease. And I essentially think of staging as an assessment of really what the burden of disease is. So we can stage it in different ways. So we can, when we do the bone marrow, we can look at the percentage of WM cells you have in your bone marrow. So how much normal blood cells are you still producing compared to how many of the abnormal cells you have. We can look at things like the level of the paraprotein as well, as a guide as to how many abnormal cells you've got. And then in terms of an assessment of your normal bone marrow function, as I mentioned, we can do the full blood count to see what the level of the normal blood cells are, and a CT scan to look to see if there's enlarged lymph nodes or spleen. But of course, all these things give us an assessment of how much disease we think you've got in your body, but one of the most important things is how you're experiencing it, because I could have two patients who come with pretty much the same burden of disease, but one person still getting on with their life and not getting that many symptoms related to it, and another person where it's completely changed their life and they're not able to get out the house, for example. And so, you know, this gives us a guide, but it's not the only thing, and there's a lot of variability. So why is assessing the burden of disease important? And as Jane already mentioned, that, you know, a lot of you will be, when you're first diagnosed, going through a period of active monitoring and not having treatment immediately. And so once the diagnosis is made, one of the main things that I think the main roles of the clinic appointment is assessing, do you have an indication for therapy? So the indications for therapy are basically driven by how you're experiencing the WM. Is there something that the WM is causing that's affecting you so much that I want to give treatment that potentially has its own side effects to make you feel better? And so there are international guidelines to help clinicians decide when might be the right time to treat patients. And the way that I kind of think about them, they're divided in the guidelines as to clinical indications, so potentially any complications or symptoms you have related to the disease, or things that we might see on the blood tests, so the lab indications. But then if you see, some of them are related to the paraprotein, and so if your paraprotein is causing problems like the hyperviscosity or complications, then we would potentially want to reduce the burden of disease to improve those complications. And similarly, some of them can be related to the lymphoma burden, so if you've got very bulky lymph nodes, so lymphadenopathy is enlarged lymph nodes, or enlarged spleen, then that might be a reason why you need treatment. And similarly, if you've got symptoms related to your low blood count, so the marrow involvement, the bone marrow being affected, then we may want to treat there. And I am going to leave it at that and hand over to Josephine in Amsterdam. So thank you very much.